Hello, thanks for dropping by today. We're going to be discussing acute diarrhea. So as always, we're going to first start with the definition. So the definition of acute diarrhea is any type of abnormally liquidy, stool with a high liquid content, or some type of like unformed stool that gets produced with high frequency. So the first thing is abnormally liquid or unformed stool at high frequency, greater than 200 grams per day, and that has to last less than 14 days. So those are pretty much the criteria to call it acute diarrhea. So if it's greater than 14 days, then that's going to be called chronic diarrhea. Also, it's kind of hard to measure 200 grams per day. So if the patient generally, claims that he's just, been having a lot of stool production, you just take their word for it and you just assume it's acute diarrhea. So what are the causes of acute diarrhea? It's pretty simple, more straightforward than chronic diarrhea. Infectious are about 90% of them. So infectious, and most common in infectious is going to be the viral. And number two are going to be the non-infectious. Obviously, that's going to be the remainder. This can include the kind of adverse effects of certain types of medication, any type of toxin ingestion that they might take. It could be ischemia to the bowel, and so when you have ischemia to the bowel, that it's not transiting as well and it's not absorbing as well, and there's definitely many others, but of course we can't mention them all, but you get the idea. Now, what do you find clinically? Well, of course, diarrhea is going to be the first clinical finding, but some of the associated findings can help you kind of figure out which pathogen that you're dealing with more specifically. So if you have diarrhea and you have vomiting, those are most commonly caused either by Staph aureus, Bacillus Cereus, or the Norwalk virus. So those are three common things to think of when they have vomiting and diarrhea. If it's watery diarrhea, you want to definitely think of, you could think of cholera or even Clostridium Perfringens, ETEC, which is Inteiro Toxins E. coli with travelers, or it could be some type of virus. Viruses obviously cause watery. And then we have finally inflammatory. And so inflammatory is going to be associated with pain and fever because it is an inflammatory process. And this can be associated with Campylobacter, Salmonella is another one. In Campylobacter. Okay, Salmonella. You also have the Inteiro hemorrhagic E. coli, and we have the Shigella. And the first three here, the Campylobacter, Salmonella, and EHEC, are actually also causes of bloody diarrhea, also known as dysentery. So that's kind of your associated findings. That's kind of what you can divide it into. Now, real quick, I just want to talk about some systemic symptoms that might be produced by these infections. One could be reactive arthritis. Reactive arthritis is associated with we have reactive arthritis and hemolytic uremic syndrome. So what are the what are the pathogens that are associated with these? For reactive arthritis, you can get it from Salmonella, Campylobacter, Shigella is another one, and also yersinia. So those are your four that cause reactive arthritis. Hemolytic uremic syndrome is pretty much only caused by E. coli, the 0157H7, and Shigella. So those are going to be two there. And real quick, let's talk about the symptoms of reactive arthritis. Obviously, there's going to be arthritis. There will also be urethritis and conjunctivits. So the joints, eyes, and the urethra are going to be affected there. Hemolytic uremic syndrome, like the name suggests, hemolysis and uremia. So those are your kind of systemic symptoms that can be associated with diarrhea. What's really important with diarrhea is your evaluation. How are you going to work up a patient like that? So of course, if the diarrhea is mild, diarrhea can be very common and it could just resolve. So if it's very mild, oftentimes no workup is necessary. The person, the patient will get better soon, and you don't need to do any type of lab investigation. However, there are some, I guess you can say in a way, alarm signs. So any patient who has these signs and symptoms, then you do want to do some sort of further investigations. So what are these signs and symptoms? First, if they have severe dehydration, in severe dehydration, you do want to evaluate further. Bloody stools. So if there's blood in the stool, you need to move further. A fever of greater than 38.5 degrees Celsius is also going to be important. If there's any history of antibiotic use, So this will generally be towards Clostridium difficile. And any abdominal pain, more specifically abdominal pain in any patient who's greater than 50 years old, and if they're immunocompromised, because obviously immunocompromised tend to get more severe diseases, and so you do want to know what's going on there. So all of these, if the patients have any of these symptoms, then you want to do further evaluation. And even with mild, if we want to go back to mild, even if mild, continues for a long period of time, even these patients, you're going to eventually want to evaluate further to see what's going on. So what's the first step in evaluation? The first step in evaluation is doing the history. And the reason is simple. There is generally a lot of different tests that can be done for diarrhea, and so you don't want to do the whole battery of tests. So oftentimes, through the history, you can try to narrow down which pathogen might be, and then depending on which pathogen it might be, you can be more selective in the tests you choose. So when you're taking the history, there's about 5 or 6 different categories you want to think of. So the first thing that you want to ask the patient is any history of travel, because patients who've traveled tend to get Inteiro Toxins, E. coli, Giardia, and Giardia is prevalent in patients who go to Russia, patients who've been swimming, and patients who've been to mountainous areas such as Nepal and those kind of areas. And also the norovirus, this is important if a patient claims that he's been on a cruise ship. So just by knowing if the patient's traveled or not, you can kind of, try to aim your lab investigations to figuring out one of these 3. You want to make sure you do that. Next, you want to ask about recent food intake. So food poisoning is obviously a common cause of diarrhea. So the first thing is meat. So there are some bacteria and viruses associated with meat. And by meat, I mean beef, pork, and poultry. So what are the bacteria here? You're going to have Staph aureus, Clostridium Perfringens, Bacillus Cereus. On top of that, we have the enterohemorrhagic E. coli. Salmonella is another one. Yersinia, and Listeria. And so these are all going to be associated with either beef, pork, or poultry intake. With Staph aureus, this is also common with eggs, so that's another thing to kind of keep in mind. Clostridium Perfringens, canned meats, is something important there. Bacillus Cereus is notorious for fried rice. So a lot of times patients may have reheated it, and the toxin of Bacillus Cereus can kind of withstand that reheating, and so the patient usually has diarrhea right after. EHEC is going to be common in fast food, specifically hamburgers. So that's something to keep in mind. Salmonella, again, eggs and vegetables, that's salmonella. Yersinia is going to be milk and cheese products, so that's a good thing to remember there. And finally, Listeria. The interesting thing about Listeria is it's very common in pregnancy, and pregnant women often have 20 times more likely to get the infection than non-pregnant people. So that's another connection you want to make there. So the other thing that I just kind of want to point out is Bacillus Cereus and EHEC. Sorry, I made that too long. Let me, 1 second. Can get that? Okay. So Bacillus Cereus and EHEC, they are not associated with poultry. So just with them two, just think of beef and pork only. What is associated primarily with poultry but not other meats? Campylobacter. So Campylobacter is one of the most common causes of bloody diarrhea. So that's something to think about. And seafood is associated with the Vibrio. So that includes Vibrio cholera and Vibrio parahemolyticus. So when you see seafood, that's the 2 you want to think of there. Next, important history is daycare. So daycares, you have a lot of kids. They tend to be pretty messy and put everything in their mouth, and so they tend to have a lot of community type of infections. So daycare, you want to think of either first you can think of Shigella. There's 2 viruses, rotavirus and norovirus. Rotavirus being the most common in infants. Giardia can also be passed like that, and Cryptosporidium. So those are your daycare associated ones. Next would be hospital acquired. So and when we say hospital acquired, they're not necessarily in the hospital, but they might have been treated with another condition. And so this is going to be Clostridium difficile. And this is going to be some type of antibiotic intake clindamycin or anything like that, one of those that can give you Clostridium difficile and lead to diarrhea. And finally, we can write over here if they are immunocompromised. So obviously immunocompromised patients, they are at increased risk of infection, and so some of those infections can be in the GIT. The most common pathogens are going to be, first of all, the common condition is going to be AIDS, and the most common pathogens is Cryptosporidium and Isospora. So those are your two associated with AIDS, and you want to keep that in mind. Also, if there is a history of fever, so I should have probably put that at the top, but I'll just write it over here. So pathogens that are associated with the fever generally mean they're invasive. So some of the more inflammatory types, and this is going to be Salmonella, Shigella, and Campylobacter. All of them cause dysentery. Some viruses as well. Entamoeba histolytica, another one that causes dysentery, and Clostridium difficile. So these all can be associated with fever. So not only that, but what you can also ask in history to kind of help you narrow down what pathogens you're dealing with is how long after ingestion of food do they have the symptoms. So if you're thinking food poisoning, time can really help you figure out which one it is, because as you saw earlier, there is a few pathogens that can cause that. So let's try to see if we can narrow it down. So generally, if the patient vomits 1 to 8 hours after eating, that means they ingested a preformed toxin. So what this means is there was some toxin that was produced by the bacteria that got placed in the food, and then the patient ingested the toxin. So they might not even have ingested the bacteria, but just ingested the toxin that was behind. The ones notorious for this is Bacillus Cereus, Staph aureus, and Clostridium Perfringens. And these patients also will be complaining of vomiting. They do tend to get vomiting and diarrhea because they're trying to remove that toxin, pain, and tends to be watery diarrhea. So that's, if they have diarrhea within 1 to 8 hours. What if the next one is going to be 8 to 72 hours? So, and these are going to be Inteiro Toxins. So what Inteiro Toxin means is the bacteria actually goes all the way into the gut, and then they start producing a toxin. So this is associated with Vibrio cholera and enterotoxigenic E. coli, so the traveler's diarrhea there. And finally, we have 1 to 8 days. These are called enteroadherent. So what this means is the bacteria actually makes it into the gut, and then it starts lining the wall of the gut, and so it prevents absorption of food into the gut, and so then that can lead to diarrhea because you can't absorb the food, and they act, they're osmotically active. So what causes this? First one's going to be enteropathogenic E. coli, which is found in infants, and enterohemorrhagic can cause that after 1 to 8 days, Giardia, and Cryptosporidium. Now, one thing that you may have noticed is there's an overlap. So this is 8 to 72 hours, this is 1 to 8 days. Obviously, there's a little overlap. So it is important to kind of be able to distinguish them through symptoms. So the enteroadherent, it's not really causing any type of damage. All it's doing is lining the gut wall, so you won't have any other symptoms other than just a very watery diarrhea because they're not able to absorb the food. Whereas an enterotoxin, they're producing a toxin, so that's going to be more similar to the one up there, which is the vomiting and the pain. So if you have vomit and pain within past 8 hours but less than 24, it's probably going to be enterotoxin, and if not, if you just have watery without the vomit and pain, you're probably looking at enteroadherent, one of these three. So that's a nice way to differentiate them. So once you've done this, there are some lab studies that you can try to go for, and these lab studies, again, based on the history, you're going to want to choose different ones. So let's go ahead right here. So let's talk about, we'll write it right here. So lab, so first you do want to do CBC, for anemia, hematocrit, and the white blood cell count, and various others which are kind of routine. What we'll focus on in particular is stool studies. So what do you want to check when there's stool? So one of the nice things to check is going to be the fecal leukocytes. And so fecal leukocytes, it pretty much means you're checking for white blood cells in the stool. So pretty simple and straightforward there. Now, which one will give you positive? Salmonella and Shigella, because they do kind of invade the gut lining, so they will kind of have this inflammatory response. But keep in mind, ulcerative colitis and Crohn's actually also will have a positive one. So that's something to keep in mind. And that's because all of these will cause some sort of inflammation. So fecal leukocytes really do help you get Salmonella, Shigella. There are some that's very unlikely, but it's not sensitive enough to rule out anything. So keep that in mind. Now, if there's blood, then you need to think of the bacteria which cause dysentery. So this is going to be the 4 primary ones. Campylobacter being the most common one, Salmonella, Inteiro hemorrhagic associated with hamburgers, and Entamoeba histolytica. So these are your 4 that cause dysentery, or dysentery just means bloody diarrhea. Next, you're going to want to do a stool culture. However, stool culture is not routinely done, and this is because you rarely get a positive outcome. So they usually reserve this if it's a particularly severe infection and the patient's suffering a great deal, then you will consider this. Next would be looking at the stool for an ova or parasite. So there are only a few conditions you'd want to do this. One would be if they have persistent type of diarrhea that's not going away, if they've traveled recently, again, daycare kids, if they're homosexual or they have AIDS, you want to check for these, and if they have bloody diarrhea but it's leukocyte negative. So that's kind of an interesting one there. So what are we doing here? So if it's persistent, if they've had travel or they've in daycare, here you might expect to find Giardia. If they're homosexual, they have AIDS, Cryptosporidium is very common with AIDS patients. And if there's blood and no leukocytes, Entamoeba histolytica, also known as amoebiasis, is very common. So amoebiasis, remember, it does cause dysentery, just like Campylobacter, Salmonella, and Inteiro hemorrhagic, but is the only one that will not have the leukocytes. So that's an interesting one there. And actually, Cryptosporidium will also be positive in daycare. So it's positive not only in the AIDS patients, but in patients in daycare. So that's going to be your investigations there. Other investigations that you might want to do, you can do a fecal antigen. So there's going to be certain antigens which will be produced and be found in the stool. These will be antigens for Giardia and rotavirus. So rotavirus is very important because that's found in infants. So that's a test you can do for them as a fecal antigen. Finally, you might want to do a test for toxin. This would be Clostridium difficile, and you'd only want to do this if there was some history of antibiotics. Otherwise, it would be not indicated. Now, the fecal osmolar gap and the fecal fat test, these would only be in situations of chronic diarrhea, not necessarily acute, because the fecal osmolar gap kind of is elevated in lactose intolerance, and then we have repeat bouts, and the fecal fat, pancreatitis, and other or some type of bile issues would be elevated in that. So those would be chronic. So, but I just want to mention them as just stool study that you might want to do. So again, we've talked about a lot of studies here. So let's kind of review before we go. So again, what you want to do first is if it's mild, there's really no workup necessary. But if they have any of these alarm signs, you do want to evaluate. And one of the first things you do is you look for history, travel history, food history, daycare, hospitalization, or immunocompromised. And depending if they have any one of those, you can kind of start looking at specific organisms that you want to look for. And then again, depending on the organisms that are there, you can do the different types of laboratory studies. So any of these laboratory studies, depending on which pathogen you're just thinking of, you want to do that. And again, you don't want to do all of these. Only be very picky and choosy on them. Okay, and so with that, we'll go and move on to treatment. So when you have a patient with diarrhea, what kind of initial treatment that you want to do? Well, the initial thing that you're worried about, it doesn't matter the severity or the age or anything, is going to be dehydration. So the first thing you want to do is you want to do the ORS, oral rehydration, should be ORT, or basically you give them, it's water with some sugar and some electrolytes placed in them. Oral is preferred, and actually studies have shown that oral is much better than the IV, but you do want to use IV if it's severe. And some people want to buy Gatorade. It's not optimal, but it is okay. It does tend to help, but your oral rehydration sachets are much better. Then what you want to do is you may want to give antibiotics. And so there is some empirical antibiotics that you can give, but this is not always required. You don't even, sometimes you don't even need to give the antibiotics, and that's because most of them are self-limiting. So if you just wait long enough, you can just limit. And the issue with this is sometimes the antibiotics can do more harm than good, and so you kind of want to balance that. Especially if it's viral, obviously antibiotics will not help whatsoever. What is the most common antibiotic used empirically? Well, fluoroquinolones. So fluoroquinolones is very commonly used, either ciprofloxacin or norfloxacin. So those are your two most commonly prescribed there. Now, if you are thinking Clostridium difficile, then you don't want to give them that. You want to give them metronidazole. And so you want to remember these bacteria are there because of antibiotic use. So sometimes they can be even resistant to metronidazole. And if that does turn out to be the case, then you can just give them vancomycin. That's kind of the second line there. And finally, if it's enterohemorrhagic E. coli, this is more serious. You actually do not want to give antibiotics. That can actually make the patient much, much worse. And this is because when you give this antibiotic, it kills the bacteria and it releases the actual Shigella toxin. So this is one of the reasons why you do not always want to give antibiotics. And of course, if you do the culture, you can do sensitivity, and then you can guide your antibiotics through there. So hope this was helpful. See you guys in a future video. Thank you.